Hello, everyone. We will get started in just a moment. Okay, I think we can get started. Good morning. Welcome to another live information session and Q&A from Clyvera. Today we are joined once again by Dr. Rohit Sud, a board-certified oncologist and also a co-founder of Clyvera. Good morning, Rohit. Thank you so much once again for joining us.
Thanks, Jane. Thank you, everybody. Happy to be here. Um, let's get
All right.
started.
Yeah, let's get started. So for anybody joining us for the first time, first want to say that this is not medical advice, and you should always talk to your doctor, but purely an informational session. So remember to always speak to your healthcare provider about any questions or concerns you have about yourself. Okay, so for anyone joining for the first time, we just want to have you, Rohit, share your background as an oncologist and also as a co-founder of Clyvera.
Thank you, Jane. I'm happy to be here and happy to see all of you here. So I spent about like over a decade treating cancer patients clinically and research, and there has been a pattern that I keep seeing. People would come in for their appointments, and it was clear that time between the visits was a kind of a black box. They weren't tracking their symptoms, they were tracking their health, things that had been changing. They didn't know what to ask. And navigating the whole healthcare system can be daunting.
Mhm,
So Clivera really came out of that frustration to help our patients have something in the corner in between doctor appointments, a tool
mhm.
that tracks their health, what's happening with their medications, helps them prepare, and connects them with the right care when they need it. That's how we came up with this, and I was lucky to be partnering with some very smart folks who helped us create this tool. So
Yes, for sure. It's a great team. Um, why? So I always let you choose our topic each month. Why did you want to discuss skin cancer for today?
honestly, because the numbers are staggering, and it should bother us more than they normally do, because skin is just skin. Skin cancer is the most commonly diagnosed cancer in the US and possibly worldwide, and it's also one of the most preventable and most treatable when you catch it early.
Mm,
That gap, frustrates me, considering that we have such great screening tools. Just seeing your doctor frequently, or being watchful and mindful of your own on changes in your skin, and such good preventative strategies, that early stage outcomes are genuinely excellent, but awareness hasn't kept up. And this happens to be Skin Cancer Awareness Month, May. And so that's, with the summer coming up, I felt it was an excellent right moment to have this conversation.
perfect. Well, I agree with you wholeheartedly, and we have a lot of amazing information today to share. So, if you're watching, keep your notebook handy and write some questions down for the end, but we'll dive right into the presentation. So first, we're going to touch on awareness and prevention. When we talk about, let's just talk generally about skin cancer first. When we talk about it, we are actually referencing several different types of cancer. Can you walk us through those main skin cancers and how they differ in terms of risk and seriousness?
So this distinction does matter because they all behave very differently. So, basal cell carcinoma is by far the most common variant, roughly accounting for about 80% of the cases. It grows slowly and almost never spreads,
Mm,
but it can cause real local disfiguring damage if you ignore it, especially on the face.
mm,
The second most common variant is the squamous cell cancer. It is a bit more aggressive, but likely to spread if you're immunocompromised. Suppose if you're on medications that kind of decrease your immune system, or for example, a lot of our patients who have had skin who have had organ transplants are on these medications, and they are at a higher risk of squamous cell cancers.
mm.
And then the most deadly is, of course, melanoma. It's the most aggressive, and it's less common, but it is one thing that actually keeps me most worried about skin cancer in general, but also it is what causes the most amount of deaths with skin cancer. It
Oh,
originates in the pigment producing cells, and if it spreads, it can move very fast.
mm.
And
That's
the good news is that melanoma has been evolving the treatment for melanoma, and we'll talk about it later. But the key point is that these are the three different kinds of melanoma of skin cancers most commonly
yeah.
seen.
Okay. All right. So that is crazy. Only 4% of the cases, but the bulk of the deaths. Is that what you said?
Yes, 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 indeed,
So scary.
and that is changing very fast, and we are so excited about it.
Yeah.
Now we are seeing long-term remissions in those cancers, so we're gonna get into that.
And we'll get to that. Yeah. Okay. So, what should people be looking for and what are the warning signs?
Ah, so, as in medical school onwards, we were taught that the most important things to do on a skin examination when you see a mole or a rash is to look at the warning signs. The acronym that was developed is the ABCDE method. A
Mm,
for asymmetry, B for the border, C for color, D for diameter, and E for any evolving changes. So it really is very useful if you're looking at moles that are lopsided, have ragged or uneven edges, show multiple colors, and bigger than about 6 millimeters in size. That is the size of a pencil eraser on the pencil head, or are changing in their kind, like color, becoming different shades like tan or brown or black, or even like bleeding red.
mm,
Then those would be actually the ones you would want to emphasize to see your doctor for. So a mole that was fine like maybe a year ago has grown a little bit, has changed its color a little bit, deserves quick attention. And then I'd also add that if anything itches or bleeds, just as I said, or just won't heal, if there's a rash that you've had that is not healed, then you need to see the doctor. You don't need to get alarmed with every spot because skin
mhm,
rashes are very common, but these changes, especially if they are persistent and and have these concerning features such as a ragged border or multiple shades of the color, definitely need to be looked at.
okay. This is very helpful. ABCDE. That's really great. Okay. So, who is most at risk for skin cancer? And is it just a fair skin issue?
No, 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 no. That is a myth. Fair skin is a real risk factor. Don't get me wrong. People who burn easy tend to have a statistically higher risk of skin cancer and melanoma especially. But melanoma doesn't care about skin tone. So, Bob Marley died of acral lentiginous melanoma, which develops on the palms, soles, and under the nails. and occurs at similar rates across all ethnicities. The
Mhm.
tragedy is that in people with darker skin, it tends to get diagnosed later
Mhm.
because the belief is that, oh, this does not affect me. It leads to less screening in those individuals, and that's why awareness is of utmost importance. The other
Mhm.
thing that genuinely matters is family history. Any history of like blistering sunburns as a kid should be a high risk feature that needs attention. A high mole count could identify genetic traits that could potentially link to a history of melanoma, amongst other cancers. Immune system status, as we talked about, can also put you at a higher risk of certain skin cancers. But by far, the sun is the biggest factor.
Okay.
But it's not the only one.
What about
There are multiple other ways that you can
on
get that same exposure.
tanning beds?
Yes, yes,
Yes,
yes,
right?
yes. Yes, tanning beds are definitely one of the things that uh, I'd love to retire that idea that tanning looks healthy.
Yeah.
That sun exposure is safe. But a tan is literally your body's response to DNA damage. Your skin
Mhm.
produces melanin as a protective reaction to the cellular injury that it is incurred when you're in a tanning bed or when you're exposed to sun. And the damage has already happened if you've turned golden. And that's the desire for many, people who go into tanning salons that, I need to, I'm too white or I'm too pale. I need to turn golden. No, that means that the damage has already happened. There's no such thing as a safe tan.
Mhm.
And tanning beds are genuinely dangerous in a way that I don't think that most people who appreciate it. So
Mhm.
WHO classifies it as a group 1 carcinogen,
Oh,
same
wow.
as as in category as tobacco. So using one before age 35 raises your risk of melanoma by around 75%.
Oh, wow. Wow.
So that's a number that kind of is jarring, but I can share a
Yeah.
patient who when I tell my patients about this, I see them like aghast looking at me. Really? I'm like, yes. Well, that doesn't mean that you will get melanoma, but your
Increases your
chances, your risk
yeah.
has increased. The risk is anyway small for most people, but that risk has increased in that quantum. So I
Mhm.
think that's what I definitely tell patients, that it's extremely important to be aware of that the tanning beds are not a
Alright.
completely
Yeah.
safe. Yeah.
I have a question. So I know that you need sun exposure to for vitamin D. So
Mhm.
balance that with sunscreen and sun exposure and cancer risk.
So the amount of vitamin D that you can get from exposure to sun in the
Mm.
current environment with the bunch of ozone layer that is actually depleted is going to be significant. That will cause damage to your skin. The DNA damage that we were talking about. So it's
Mhm.
better to take a pill
Oh,
for a vitamin D deficiency, and I definitely do suggest that that's important to do that. Unfortunately, we have tinkered with our environment way too much, that sun exposure of any degree at this present time, and we have better awareness, is not the best way to get vitamin D.
okay. Very good. I'm glad I thought of that and asked that question because that's something you hear about a lot. So, okay. Can we discuss? So, to further that conversation about sun exposure, let's look at sunscreen.
Mhm.
Um, there is a lot of confusion around SPF,
Mm.
and also, how to use it properly. I think sometimes somebody thinks they put the 100 on early in the day, they're good for the rest of the day. Um, you know, not true. So if you can walk through with us and tell us kind of
Yeah.
what should we
So
be
there
using?
is so much confusion.
Yeah, so much
It ha-
confusion.
it
So if you can,
happens each time we go out hiking or to the beach with my kids, or
yeah.
even when I'm talking to my patients, that why do I need to apply that much? Why do I need to apply it so often?
Mm,
But there is a lot of confusion about it. So I'm glad that you brought this up. So I think actually discourages people to apply sunscreen because this is too confusing. So when you go into the aisle in the grocery store or the pharmacy, there are multiple SPFs all around. SPF
Yeah.
30, SPF 50 is better. SPF, we are 100% SPF protection. There's nothing like that. So
Hmm.
SPF 30 filters about 97% of the UVB rays, which are the harmful rays, and SPF 50 filters about 98%. So that's not a big difference. The
Hmm.
gap is much smaller than what the marketing actually suggests. Of course, the
Yeah.
price difference is huge, and people think that, oh, well, if it's expensive, it's better, but not really. So the bigger issue is application, though. And that's not what people talk about. So, most people use about a quarter of what they really should.
Hmm.
So for a full body, you roughly need about an ounce, like a shot of, like a shot glass, and for a face alone, a nickel-sized amount, and it's needed to go on your skin at least 15 to 20 minutes before you go out into the sun, and reapply it every 2 or 3 hours if you're outside for longer.
Hmm.
And that's something that we do tend to forget, and especially if you're swimming and sweating, you are basically washing out all the protection along with. So it's imperative that you do apply that, and keep that reapplied. The other thing is knowing that broad spectrum, it means that it covers both UVA, which causes aging and a deeper skin damage, and UVB, which causes burning.
Hmm.
So the protection of the SPF is only for the UVB, but it also protects against the UVA, which is the one that actually causes the skin damage. So
And UVA and UVB both increase risk for skin cancer, correct?
exactly, they do. So you ideally want a sunscreen that has both UVA and UVB protection.
Hmm.
And it should say on the tube as to what it is.
Okay. And then what about mineral? You see that a lot nowadays, mineral, mineral, mineral. So what's the difference between mineral and chemical sunscreen?
I think whatever works for you as far as your
Hmm.
skin sensitivity
Yeah.
should be applied, and the application is what really matters. So
Hmm.
use enough, use early enough, use it often, and use it daily. So
Okay. So
that's
so
what.
long as it's broad spectrum and you use
Yep,
it,
I know.
that's
You go into my daughter's closet, you'll find various different kinds of sunscreens. But when you ask her, did she apply before she went out? That's the that's the $1 million question.
right. Okay, so now let's go to screening. Let's talk about screening. Um, what does a skin cancer screening from your health professional involve? And is it something people need to specifically request from their doctor, or does it happen automatically?
So most of the time you need to ask, like that you need a full body examination. So I think those discussions, I think you have a slide on that, do you? In which you ask about a formal full body skin exam from a
Mhm.
dermatologist,
Mm.
preferably. It's a look
What is
through
your
from.
physical, primary care? You?
So primary care practitioners also should be able to do it, but they
Mhm.
typically don't have the dermoscopes, and they
Mhm.
don't have that ability. But they will be able to identify, based on your genetic history, based on at least the number of moles that you have in your skin, based on the extent of sun damage that they see on your skin, which could be not essentially only cancers or squamous cell or basal cell cancers or melanoma. There could be pre cancerous skin damage conditions like actinic keratosis and other sun exposure changes, like aging related sun exposure changes, which could prompt them to actually refer you to a dermatologist, which may then lead to a full exam. So of course, your normal healthcare, your primary healthcare practitioner is an important conduit to looking at that screening. So bringing it up to your primary care physician, who should also discuss this with you based on what kind of lifestyle you have, what kind of family history you have, would be able to tell you exactly what your risk profile is and uh, how to define that better for you as far as a proper dermatologist-based screening would be required or not. But
Okay. Okay.
you need to ask, yeah, for a
And
full
that
body.
situation would determine kind of how often you would go to the dermatologist.
Exactly. Yeah.
Okay. Got it. Okay. So what about, I know self exams are important as well. We talked about that with breast cancer.
Yes.
It seems we're looking at our skin all the time, right? So
We do. Yeah.
what do we
So
do for a self exam,
I know. So you look at everything, but the
but
most
not your
important
back?
thing, yeah, it takes about 15 to 20 minutes to actually go through all of that. But many patients, many times we basically just look at look at it from the perspective of okay, I have a mole, I have a scar here, it doesn't look good, but essentially looking at at moles from the perspective of okay, fine, this was there yesterday, or this was there last week or last month, and has it changed? Paying attention not only to your face but your lips, at your hairline, looking at the back of your hands and arms, taking off your shirt, looking at your chest, and having someone take a look at your back, looking under your nails. Those are all
Mm,
extremely important things that you would miss if you were not actually paying a good look at a full body self examination. It's a good you don't have to do all of it at the same time. If you're like
mm,
doing makeup, maybe you could look at your face and your scalp and hairline, or if you are like applying lotion, look at the back of your arms and hands. If you're cutting your nails, look at your nails and your feet. So I think it's if you just have to get into that pattern of feeling that ownership of involving yourself in
mm,
taking care of your skin for
mm.
the most part. And everyone should do that, women, men, anyone who actually has had any sun exposure, I would say,
Which
even
is,
when there is no sun exposure actually.
yeah.
Yeah.
And I have, right, for the most part. Okay, let's go to early detection and discuss that as part of screening. There's a lot, we hear a lot about how important it is. You've touched on it a little bit. Can you kind of dive deeper on how important early detection is?
Yeah, so there is uh, um, uh, there is no universal guideline, by the way, we have for colonoscopies. So this is really mostly individualized. For average risk adults, we start an annual full body screening, both with the PCP and, as we talked, eventually to a dermatologist to do a full body skin examination, which can take about 20 to 30 minutes in in a doctor's office.
Mm,
I think that should start for an average risk adult in their 20s and 30s.
mm,
So monthly self-examinations should start even earlier.
mhm,
Honestly, and now for anyone watching, that's important to know. For patients with family history of melanoma, a lot of atypical moles on their skin that actually are changing the shape and say and size. They have someone who has had significant sun exposure as a child. They were spending all of their summer, in the trunks and in the pool, or in the beach, or in the wilderness. They should be more cognizant of this. They should have more frequent checks, every 3 to 6 months even. That might be what they need. That's totally worth a specific conversation with your PCP and then eventually a dermatologist. And what we really hear about is that early detection, and the numbers of melanoma are actually staggering.
mm.
If you catch melanoma in stage one, that localized, thin, hasn't spread, the 5-year survival can be almost 100%.
Wow.
98 to 99% have cure rates just by a local excisional surgery and this constant vigilance subsequently. And most melanomas are actually found by diligent testing in stage one.
Hmm.
In stage two, when it's a little bit more deeper spread, and that does happen in certain melanomas that are harder to actually identify by clinical evaluation, it does drop to 80%. And by the time the cancer has spread out to other parts of the body, the survival rates, 5-year survival rates are down to around 30%. So same cancer, but different outcomes at different stages, and entirely curable in the in if it's found very early. So
Hmm.
that gap, 30 to 99%, is what makes me feel strongly about screening and prevention and using sunscreen. And we're not talking about marginal differences here. We are talking about someone, whether someone's alive in 5 years after such a diagnosis. So
Yeah.
I think it's extremely important to consider. This is probably one of the most important slides on melanoma that you can show our viewers, that this is a take-home message, that it's imperative that you get to do some screening and
Yeah.
ownership of using the sunscreen a little bit more.
Yeah. Yeah. Okay. And I know this is melanoma is it makes sense to discuss it specifically about melanoma. I imagine it's similar, right, for the other two types?
Yes. So as I said, basal cell cancers are more disfiguring. So
Hmm.
it's if it's found early, the extent of surgery that would be needed for it would be much less, and they are
Yeah.
the more common cancers. So you don't think about survival as much for those cancers, although if they actually do advance and extend into the into rarely basal cell cancers of the skin can metastasize, but squamous
Okay.
cell cancers can metastasize. Then you
Uh-huh.
need a more involved treatment, including radiation and
Mm.
chemotherapy and certain new drugs that are now available, that are pill form of treatment, that can target certain pathways that these cancers exploit to grow, and we can use that to actually to even provide long-term remission and even cure. But the challenge is with these cancers, both squamous and most commonly with basal cell cancer, they become disfiguring.
Yeah.
And that's why it's imperative to actually find
To
them
get
early so that those things can be addressed.
yeah. Okay. All right, excellent. Such good information. Okay. Oh, let's talk about technology with screening. So AI and imaging technology used more and more in dermatology. What is available now for consumers and clinicians, and how reliable are these technologies?
Yeah, so AI is disruptive, right?
Hmm.
AI is an emerging technology. It's disruptive. It is going to be it's going to what is going to change the world and us, and it is clearly not touched medicine, I should say, using a double negative there, but it has been it has been affecting medicine as much as any other field. So on the clinical side, FDA has cleared certain AI tools to analyze dermoscopic images, and this and with a sensitivity that typically approaches, or even sometimes, don't say that out loud, matches or improves upon trained dermatologists in controlled settings. So that is really impressive, and I think more and more dermatologists have incorporated those softwares, as they are now FDA approved, into their assessments. And if you go to your dermatologist office, they'll say that, oh, we are using this AI tool to actually to assess your images, and how do you feel about it. So many a times, people get nervous about sharing information onto the, but these are very safe. They are FDA approved. They are vetted tools, and so it's imperative that you actually use that technology, which only enhances your dermatologist's ability to actually diagnose these conditions.
Hmm.
But on the consumer side, things are a little bit more mixed. Your smartphone apps have been developed, multiple of them, which show reasonable performance, but they've not been studied as rigorously. Some have, but others haven't. So it's that performance is also very variable. So the fundamental limitation is consistency. you know Camera quality, lighting conditions, most users aren't trained how to capture the image into the algorithm. So the algorithm will work only as well as the user.
Mhm.
So the bigger concern is what happens after. Does the app tell you, flag you that there is something that's wrong, or you just leave the result and then move on? There's no clear next step. So I think those are things that we don't have a very clear understanding on these smartphone apps. They are now they're available. Everyone has a camera, front facing, back facing, but they're not. Uh, they're not prime time, I would say. There's no alternative to your doctor and the dermoscopic evaluation.
Okay. Good to know.
Yeah.
Emerging technologies, what are you excited about on that field?
Oh, the pipeline is extremely promising. The emerging technologies. There's a reflectance non-focal microscopy which lets clinicians actually examine skin at near cellular resolution
Mm,
without a biopsy. So it's
wow.
essentially an optical biopsy. You can just use a microscope onto the skin, attached to a dermoscope to identify what is it that we are seeing. There is additionally electrical impedance spectroscopy, right, which measures the electrical property of the tissue and distinguishes it from benign versus malignant lesions. And there's an interesting work on multispectral imaging, which picks up and the changes below the skin surface that you can't see by the naked eye. So I think it's those are all important new technologies, still unproven. We don't have anything FDA approved yet. So
Yeah.
but the pipeline is clearly emerging. Just because there's a strong need for this, as you can see,
Yeah.
it is one of the most common cancers that we see. So.
Right. All right. Very cool. Okay. Let's go to our last stage.
I
Oh,
have
yeah.
to
Go.
say but the bigger picture, I'm extremely excited about the shift from a snapshot approach to
Mhm,
more of a continuous monitoring. So whether it is your smartphone app, or whether it is instead of catching something on an annual exam, if you
mhm,
can actually track the changes over time, that is very much the field where the field is actually heading. And we
mhm,
talked about this ABCDE phenomenon. It's not something that we can actually be tasked to. There are too many things that happen in our lives anyways every day. So
mhm.
what I'm excited, I think Clyvera and patient engagement in that situation can help track those changes over time passively. And that's very much where the field is also heading. So I'm excited that how Clyvera thinks about this, when we have patient engagement actually improve in owning their own skincare.
Yes. All right. Excellent. Okay. Diagnosis and treatment. If someone has a concerning something flagged by their doctor, what
Mhm.
happens? Can you walk through that process with us?
Okay. So you see a primary doctor, there is a change in the type of the mole, not certain what it is. The first step is to take a closer look. So you see a dermatologist with a dermoscope. It's a handheld device. They with appropriate light and magnification, they can see what changes in the skin are happening, if there is anything under the structure of the skin. And now we of course have AI improving that assessment. So if something looks suspicious, the only way to know what it is a biopsy. So biopsy is commonly done. It's excised it's shaved off. It's removed with a small margin of surrounding normal tissue and sent to pathologist for examination. Dermatopathologists are an extremely brilliant different breed, who would evaluate that punch or an excisional biopsy, and look at it under a microscope, stain it with to improve the viewability of any abnormal cells. And if a cancer is confirmed, the pathway then depends on what kind of cancer it is, how advanced it looks, how deeper involved it is, whether there might be more imaging needed to actually check for any spread. For example, for melanoma especially, there is also something called a sentinel lymph node evaluation that we might do to determine if the lymph node basin from where the blood flows into the body from that cancerous spot, whether that is involved, whether the cancer has reached the lymphatic system. The process is fairly well defined and is essentially algorithmic at this point, and you're not waiting months. Once you get a confirmation of the diagnosis, things move very, very quickly, especially
Mm.
if it's a melanoma, and most patients have a treatment plan within 3 to 4 weeks.
Okay. Wow, that's amazing. What does
But
a t
you do need a multidisciplinary team
yeah.
to individualize a care strategy for you,
Mm,
because dermatologist does the biopsy, the dermatopathologist assesses it,
mm, yeah.
and then they work with the oncologist and the surgeons, as well as some special Mohs surgeons who are also dermatologists, to do various kind of surgeries that might be next steps and staging evaluation. So it's a whole team that actually then
Mm,
gets together to actually to collate all that information and get to the right answer.
okay, got it. Okay, so when we're looking at treatment and a typical journey, um, what does it look like for someone staged early versus advanced?
Okay. It's enormously different for
Yeah.
early stage skin cancer. Treatment is often very straightforward. You know it's mostly surgical resection, excision of that tumor, including with some that tumorous area, or when I say a tumor, basically that cancerous spot, with some normal margins, which might involve most surgery for cosmetically sensitive areas, such as the lips and face and around the eyes. Sometimes even cryotherapy and topical medications are used for certain kind of cancers, like basal cell and squamous cell cancers. For melanomas, we typically do a wide excision, like because the data suggests that if you have at least a centimeter of margin, these patients typically do better because wide excisions are curative.
Mhm,
And then you would do certain lymph node biopsies in certain patients that might be helpful to either stage or even cure these cancers. So typically, cure rates, even in advanced melanomas, can be around 96 to 99%.
okay.
Not advanced, but localized
No,
melanomas.
early. Yeah, yeah, yeah.
Yeah. So for advanced disease, the story is very different. It's
Mhm,
actually definitely changing very, 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 very rapidly in all kind of cancers, including melanoma, which is the most feared of all the skin cancers that we see.
mm,
These days we have immune therapy, the checkpoint inhibitors. You must have heard of Opdivo or Keytruda. It's always on television. These are the checkpoint inhibitors that actually target PDL1 and PD1, um, uh, um, uh, uh, which are helpful in actually engineering your immune system to attack the cancer,
mhm,
and using those markers, the PD1, PDL1s, and certain they improve the attack rate for your immune system to these cancers. Additionally, there are certain melanomas, about 50% of them, they have BRAF mutations. The BRAF is the RAF-RAP map kinase, is the growth pathway that most cell lines use to actually have a growth advantage. So if there's a mutation in that pathway, then that cell line tends to grow much more rapidly. So if you have a BRAF inhibitor, which we have multiple drugs out today that can actually attack those patients actually tend to respond beautifully. I've seen patients having aggressive disease with multiple organ involvements. You give them a target drug, it melts away, and it is it's like turning the switch off. And so these new changes with all these checkpoint inhibitors and targeted therapies have clearly changed the median survival of advanced melanoma. When I'd gotten into training, uh, um, uh, advanced melanomas would last, our patients would last about 6 months, 9 months.
Mm.
But now with these new therapies, I've had patients completely cured and treatment free.
Wow.
Like it is so heartening to see them come, because we do tend to continue to follow them for a while, um, and they have been disease free even after stopping treatment.
Wow.
So like 2, 3, 4 years. So it's amazing, and that is data is still evolving as to what all in patients who do respond. I would say that those are the remission, long-term remissions we are seeing. Unfortunately, there are still certain variants that we don't see responses in as robustly. Patients who have gotten checkpoint inhibitors or have those mutations do not respond to those target inhibitors at times, because there are other downstream targets that we are not able to yet identify or even attack yet. So I think it is extremely important to participate in clinical trials, and your doctor will be your best person to tell you, okay, this is something that you can actually you should partake in, because your cancer is not responding to the current treatments that we
Mm.
have. And of course, there is a role for surgery in certain metastases or advanced cancers that you can actually get long-term remissions from as well.
Okay. So you kind of started to talk about it, but let's look at the change of,
Oh,
you know, the
oh
last
boy, this is this
or
this this would this would be a discussion for a medical conference, literally.
yeah. You can just
But
highlight,
as
not to
you
go too
can
crazy.
you can see, before it's literally pre-immunotherapy, if you look at it. So the median survival was about 9 months. We had really, really rudimentary chemotherapy in dacarbazine, which was the standard of care at that time. Eventually they created a pill form of treatment with it called temozolomide, which we used for a while. But these patients had a 5-year survival of less than 10%. So it was really, you know, most of our patients did not actually make it.
Mm.
But in 2011, the first immunotherapy medication, the CTLA4, were approved, which was very effective in treating, but very toxic. Most patients who got CTLA4 in the dosages that we actually started, it did change the picture. Our patients started living longer, and we knew that proof of concept, it worked, and it got approved really fast. Um, uh, but then we started seeing, by 2014, newer drugs come out, the PD-1 and PDL1 inhibitors, the Keytrudas and Opdivo started coming out with much better tolerance and response rates of around 40%. Then we said, okay, fine, we have one drug which really works very well, but is very toxic. We can't give it for long term, but we have this other immunotherapy that is good. How about we combine those two? So we in the pivotal trials in 2016-17 were combining ipilimumab, which is the anti-CTLA4 inhibitor, and the PD-1 inhibitors, uh, to effect a response, and those response rates clearly showed that there was a meaningful improvement. Response rates were much better, and our patients had a survival of over 70 to 80%. So this slide
Mm.
says around 5-year survival rates rises around 50% in trials. But yes, but we are seeing now longer term survivals in these patients. So now we even using in certain more advanced, like stage 3 melanoma, stage 4, stage 2 melanoma, certain high risk adjuvant immunotherapy. So basically giving them preventative immunotherapy before something actually develops as stage 4 for them.
Mhm.
So we are seeing that those patients are living longer for over 10 years,
Wow.
with no cancer coming back. So it has clearly changed the way that we see melanoma. Melanoma used to be a death sentence, but not anymore in all cases. But yes, it still is a deadly disease, but
Mhm.
things are changing very rapidly. It's very exciting to be an oncologist at this time when you're seeing, as you can see, this has been my career. This has been like my from the time I finished my training, that was in 2009,
Mm,
to now.
yeah.
It has exploded, and I'm excited to see what's ahead. I think medicine and oncology is definitely very, very fast growing, and just gives me goosebumps each time I see something new come up.
That's really neat. Well, and combined with, the leaps we're making in technology and AI with
Yeah,
with treatment and I mean with screening, not treatment, with screening, so
exactly. Yeah.
pretty amazing.
Yeah, and and AI is actually helping us define targets.
Mhm.
So, drug development models are using AI in actually figuring out uh, which targets might be more effective before they actually make the molecule to affect clinical trial.
It's so cool.
Yeah.
Okay, we're coming up here on the end. We're getting close to our Q&A time. As a clinician, what trends and or gaps do you see in how patients are tracking and managing their skin health between appointments?
So the
And I'm
continuity.
grow up, so everybody Clyvera is an app that's leveraging AI to help people manage their health. And so we have a different approach than just popping stuff into Google or even a current AI tool. So we'll leave this up here so you can kind of see how we're different. But I would love to hear just, you know, I think it goes to why you started and co-founded
Yeah.
Clyvera. Where are the gaps that you're seeing?
So as I alluded in the beginning of our talk, Jane,
Mhm,
the continuity gap is the biggest one. you
mhm,
know Now that we're talking about skin cancer, let's just talk about moles that have been slowly changing over 8 months, that might not register to a naked eye, but annual examination, or maybe every 15-month examination, may be too late for that mole. And but also because patients move, they may not see the same primary care provider.
mm,
Documentation may be not as effective as it would be, so there may be nothing to compare it to. So the patients, many a times I see, they can't describe when they first noticed it and what changed in how it looks now, compared to 6 months or even a year ago. So memory is, as good as it is
mhm.
genuinely unreliable in this
Yeah,
stuff. So I think,
yeah.
if a patient comes to me with a log, photos, dates, times, notes, then it it might be it might help the physician, or any care provider, to or themselves, to evaluate that change over time, rather than just one point in time
Mm,
snapshot. So Clyvera's symptom tracking is built for exactly that. Patients can document what they're observing, and record. That record becomes part of their conversation in the next visit with the doctor, and that is the dynamic responsibility that we are trying to bring to your own care. And that changes the interaction with your provider, as well as the dynamic of care completely. And your appointment preparation is better. You're able to see a clinician backed content. You're well educated, and I think that does increase compliance, and that's where we are hoping that using such tools, like Clyvera, will help our
mm.
patients be more
Yeah,
informed.
yeah. Um, so you kind of talked about this earlier, but there are apps out there that claim to analyze moles and spots.
Mhm.
What should consumers be thinking about when evaluating these types of tools? And you can talk about how we approach it a little bit differently too.
Yeah. So, these apps that you have for mole identification, uh, the most important thing for you to ask of the have they been clinically validated by clinical trials?
Mm, mm,
Most of them have not. And then in what population does it affect you, your skin color at baseline? Has it been tested with diverse skin tones? What is the sampling? How many patients were tested? So there are multiple things. So FDA approved apps would generally do that,
okay.
and that's why it matters most that whether you actually rely only on a skin rash identifying app versus going to your doctor.
Yeah.
The other thing is whether the app actually will flag something if it sees, and will connect you with your primary care. So the risk is that a poorly designed tool like that in both directions may actually lead to either false assurances or just unnecessary anxiety.
Mhm.
Where a tool flags something that's benign and sends you on a spiral.
Mm.
But so so I think that's the most important thing to actually to look at those apps, whether or not they are. I would just say whether they are FDA approved or not, whether they have
Mhm.
that vetting behind them or not. So our approach in Clyvera is very different. We are not trying to replace any clinical judgment. This is basically we are just giving you tools to actually make you better prepared.
Mm.
We're not trying to diagnose anything or even fundamentally change your clinical care, just to document the chronology and define how you can see that particular change for yourself and help prepare you to be with your doctor in that situation.
Okay, cool. And another big piece is privacy and HIPAA compliance, which is really important when you're talking about your personal health data, correct?
Yes, 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 yes.
Can you
It
touch on that
really is.
as well?
And I think people are too trusting here. A
Mhm.
lot of consumer health apps are not covered under entities under HIPAA, meaning
Mm.
that they have no legal obligation to protect your health information the way a hospital does, or a pharmacy does. The data can be sold to advertisers. They can send you, what kind of sunscreen you need to use.
Mm.
Most people, actually don't even read, and I would consider myself as one of those, the privacy policies and details and how it really all
Mhm.
happens, right?
Yeah.
So when we were building Clyvera, we built it from ground up to be HIPAA compliant. That was the foundation of how we wanted to start this. It was not an afterthought of going into the development of the app. So when the
Right.
patient shares the health information with us, it's encrypted, it's secure, doesn't go anywhere without an explicit consent. And patients deserve to know that that's not a default across the country.
Yeah.
And so many apps that you may have, and may not have that HIPAA compliance or that compliance built into them. So
Right.
you should always choose tools that actually take those things seriously.
Right. And I think the idea of um, privacy built into our design, that's something I learned about starting to work with Clyvera is it's really tricky to make it HIPAA compliant, right? And if you're using the
Retrospectively,
cloud and
yes.
all of these things, and so it really is a big deal to have the technology be considering that from the very beginning rather than adding later is really difficult. And so just assume something's not private unless they're telling you specifically it's HIPAA, HIPAA compliant, correct?
Right,
Right?
right. Yeah. Just like you trust your doctor's office, you sign that waiver, and there is a system in which
Right.
the doctor's information
Everything's
is
protected.
tracked,
Yeah.
and has to be HIPAA compliant. And it's
Right.
so we when we were building the app, we considered HIPAA compliance as that foundational relationship,
Mm.
understanding between the user and the app. That okay, fine,
Right.
you are safe here,
Right.
and your
Right.
data is safe here.
Right. It's really important. Okay. As we head into the Q&A, I kind of want to do a few high-level key takeaways with you. What is the one thing that you wish everyone watching today knew about skin cancer that most people don't, or that they get
So
wrong?
So there is no safe tan, as you mentioned here. Use at least the SPF 30 broad spectrum screen and apply it like very very liberally and make it a daily habit. Uh, uh, you know, know that it's not that if you have a darker skin, you would not get skin cancer. There are multiple different kinds of cancers. We talked about Bob Marley, getting skin cancer, melanoma, and it affects all skin tones. Early detection makes all the difference between 30 to 99% in survival, especially in melanoma. So monthly self-examinations, if you can do, and annual skin check-ins with your PCP are extremely important, uh, but also tracking any changes in the moles that you might see as you do those self-examinations. The ABCDE category of categorization is extremely helpful. Um,
Yes.
so I know many people will hate me for this, but say no to tanning beds. It is a proven carcinogen. We cannot promote, just like yeah, it is not something that should be done. But I know it. This is a very personal thing for many people. But I
Yeah.
I tell all my
Yeah.
patients not to. Um, and the other thing is that there is hope.
Hmm.
That's the most important key takeaway, I think, in managing skin cancer, that we are seeing great great promise with immunotherapy and target treatments, and I'm hoping that we will call this like had been at one point.
Yeah. Okay, I want to jump into questions because I think the last questions I was going to ask you, we've already covered. So, if anyone has questions, you can put them in the comments. And I have a couple that were submitted ahead of time that I can jump into while we wait to see if any questions come in. Um, Let's see here. So, I most think about my skin once I have a sunburn. Should I be worried beyond that? And also, should I be worried once I have a sunburn? What does that mean for the future?
Yes, so sunburn is one of the the most important things, that and glaring example of how damaged your skin has become.
Mm,
So if you've had sunburn, and especially if they're blistering skin burns, then your skin has sustained the DNA damage.
mm,
So it's extremely important to be aware of that. We consider a skin burn, a sunburn. Okay, fine. This will pass. It just is going to be discomfort on my shirt for a while, but no. And the peeling of that skin that's happening, that's the healing process that's happening, that can can be a sign of a DNA damage that may have happened. You don't know for sure that it's happened, but it is a possibility that sunburn has caused DNA damage. Now,
and that damage
how
can manifest
can
decades down.
manifest as any of these kind of cancers, like basal cell skin cancer or squamous cell skin cancers, which you commonly see in older. The other day I was talking to my landscaper who was showing me a non-healing like a wound from on the back of his dorsum of his hand, and I said
Mm,
that needs to be taken a look at, that needs to be excised, because they are outside, and
mhm.
they unfortunately do get those sunburns,
Yeah.
and many times go unnoticed. So
Hmm.
yes, I think once you have a sunburn, you should not be alarmed, but be worried about it, that it should be actually not at that particular instant of, okay, I have that discomfort, but going forward, how do you actually evaluate this
Right.
with screening, enhanced
It
screening?
it reshapes that. Like my biggest takeaway is that there are, like you said, with the colonoscopy, it's pretty like every 10 years for everybody, right?
Yeah,
But in this case, it's very individualized. So if
it's
you've had a
very
lot of sun,
individualized.
then your risk is up and you need to be a little more aware and pay more attention. Right? That kind of just sort of reshaping how you look at what your risk assessment is.
Indeed, yes.
Um, So, my doctor has never mentioned a skin cancer screening to me. Should I be asking for one, and how do I bring it up?
Yes, yes, and yes. So, because there is no guidelines for like you have for mammograms or colon cancer screening, that does not mean that you should not bring it up. It should be something that should be front and center and unfortunately missed by way too many doctors
Mhm.
unless a mole is brought to their attention. So, general screening by the doctor, a complete skin examination in the nude should be done. In addition to your self examination, you see them maybe once a year if you're a healthy person. I think at least that's your contact with the healthcare provider, then that it should be done. And you
Okay.
should bring it up.
And don't be afraid to bring it up, right?
Yes, don't be.
um, so the darker skin tone, I have always assumed I didn't need to worry as much about skin cancer. Is that true?
No, not at
You
all.
covered that, right? No.
Not at all. Not at all. Darker skin tones also get skin cancers. They also get melanomas. And
Mhm.
because they have delays in those diagnoses, they tend to be more advanced. So it's
Okay.
extremely important to
So it's
actually,
even more important to really pay
yes,
attention if you have darker skin.
yeah.
Which- Yeah. Okay. Um, so we talked about this a little earlier, but I think it would be good to revisit. They had asked, what's the difference between a dermatologist and my regular doctor for skin screening? And do I need a dermatologist? And I guess, then people, if you're on an HMO and you need referrals and all of that, yeah, how important is it to go to a
So
dermatologist?
very important when you actually see a dermatologist, they have special scopes,
Mm,
special expertise that your primary care physician does not have, even your oncologist does not have.
mm,
I have many patients that come to me and say, "Hey, doc, I'm seeing you for colon cancer, but I have the skin thing that happened. What do you think of this? Do you think I need to be worried?" All tell them is, you need to see a dermatologist.
mm.
Let's get this thing and look at,
Okay.
and that's important because they have those special dermoscopes, those newer technologies, those and the clinical knowledge to actually look at the skin and figure out what it is. So I think definitely go to a dermatologist if there is something abnormal on the initial screen by your primary care provider, or if you have any sort of skin damage from sun damage from exposure.
Okay. Ooh, this is a good question. Does skin cancer hurt?
Yes and no. So the disfiguring cancers like basal cell skin cancer can actually involve certain nerves and
Mm,
can be very painful, can cause very big ulcers in the skin, and can also invade through the muscle, and patients can have disabling pain with those things. So it's extremely important to be aware. Otherwise, other cancers, for example, squamous cell cancer of the skin, uh, uh, if it's again more locally advanced, can be painful um, because of nervous involvement. Melanomas can go to bones and other organs, including uh, uh, certain melanomas tend to involve more internal organs like the peritoneal cavity, the pleural, the covering of the lungs. Those can be painful in their own right. Muscle involvement is also common with these melanomas.
mhm.
So yes, they can hurt if it's advanced, but also locally they grow.
Interesting. Okay. All right. We're a little over an hour, but there's one more question that's here that I think is good. We haven't mentioned a lot about genetics and family history here. Is that significant with skin cancer?
Yes, yes, yes. There are certain melanomas that have a genetic correlate, the CDK1 inhibitors, like gene mutations are actually associated with an increased risk of melanoma. So patients who have family clusters of melanoma should be tested by such genetic mutations,
Mm,
and patients who have had family history of melanoma should bring it to their physicians for an enhanced screening.
Okay. Okay, good. I'm glad that question got asked. Okay, that's it. Is there anything else you want to say before we close and sign off?
No, I would say go out, enjoy
Oh,
this summer
we have one more quick
responsibly.
question. One more quick question. It
Yes.
just came. Can skin cancer spots itch and look like dry skin?
Uh, Not commonly, but yes, it um, uh, uh, if it ulcerates or if it bleeds, then it certainly is concerning that should be looked at.
Okay.
Typically, dryness would be self-evident
Mm,
with and may get better after applying some lotions. But if it persists, and if it's a patch that is that changes its color, then it should be taken a look at.
okay. 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 Now I'll let you finish what you were going to say.
Well, I was just saying that enjoy the summer. Do
Yeah.
not do not please consider this webinar to be dissuading you from enjoying the summer
Yeah.
responsibly. Though enjoy, go into the pool and have your barbecues. Go out hike. It's beautiful out there. Enjoy the open skies, but
Just
use appropriate sunscreen.
right. Yeah.
Yes.
Put enough on and put it on regularly. That's
Yes,
what
put
I
enough
learned.
on and go back to the acronym of ABCDE
Hmm.
always. Yeah.
Yeah. Okay. This was amazing.
Well,
Thank you. Appreciate it.
thank you, Jane. Thank you, Jane. It was a pleasure. Thank you, everyone, for joining us.
Yes.
We look forward to having
Have
you
another
in
one.
another webinar.
Yep. Yep. Sounds great. Okay. Thank you.